Cardiopulmonary Resuscitation. Yashar Kakardal MD. Yeditepe University Medical Faculty. Internal Medicine, Intensive Care. The Paris Academy of Science recommended mouth-to-mouth ventilation for drowning victims in 1742. In 1891, Dr. Friedrich Maas performed the first documented chest compressions on humans. 3. The American Heart Association, AHA, formally endorsed cardiopulmonary resuscitation, CPR, in 1963, and by 1966, they had adopted standardized CPR guidelines for instruction to lay rescuers. 2. The American Heart Association, AHA, developed the most recent ACLS guidelines in 2010 using the Comprehensive Review of Resuscitation Literature performed by the International Liaison Committee on Resuscitation, ILCR. 4,5. Because of the nature of resuscitation research, few randomized controlled trials have been completed in humans. Many of the recommendations in the American Heart Association's 2010 Guidelines for Advanced Cardiac Life Support are made based upon retrospective studies, animal studies, and expert consensus. 5. In the past, clinicians frequently interrupted CPR to check for pulses, perform tracheal intubation, or obtain venous access. The 2010 ACLS guidelines strongly recommend that every effort be made not to interrupt CPR. Other less vital interventions, e.g., tracheal intubation or administration of medications to treat arrhythmias, are made either while CPR is performed or during the briefest possible interruption. Interventions that cannot be performed while CPR is in progress, e.g., defibrillation, should be performed during brief interruptions at 2-minute intervals, after the completion of a full cycle of CPR. Studies in both the in-hospital and pre-hospital settings demonstrate that chest compressions are often performed incorrectly, inconsistently, and with excessive interruption. 7 to 11. Chest compressions must be of sufficient depth, at least 5 centimeters, and rate, at least 100 per minute, and allow for complete recoil of the chest between compressions, to be effective. Patients are often overventilated during resuscitations, which can compromise venous return resulting in reduced cardiac output and inadequate cerebral and cardiac perfusion. A 30-to-2 compression to ventilation ratio, 1 cycle, is recommended in patients without advanced airways. According to the 2010 ACLS guidelines, asynchronous ventilations at 8 to 10 per minute are administered if an endotracheal tube or extraglottic airway is in place, while continuous chest compressions are performed simultaneously. 12. In the 2010 ACLS guidelines, circulation has taken a more prominent role in the initial management of cardiac arrest. The new mantra is, circulation, airway, breathing, CAB. Once unresponsiveness is recognized, resuscitation begins by addressing circulation, chest compressions, followed by airway opening, and then rescue breathing. In the non-cardiac arrest situation, the other initial interventions for ACLS include administering oxygen, establishing vascular access, placing the patient on a cardiac and oxygen saturation monitor, and obtaining an electrocardiogram, ECG. 5. Ventilation is performed during CPR to maintain adequate oxygenation. Ventilation is performed during CPR to maintain adequate oxygenation. The elimination of carbon dioxide is less important, while normalization of pH through hyperventilation is both dangerous and unattainable until there is return of spontaneous circulation, ROSC. However, during the first few minutes following sudden cardiac arrest, SCA, oxygen delivery to the brain is limited primarily by reduced blood flow, 18,19. It is widely believed that a lower minute ventilation is needed for patients in cardiac arrest. Therefore, lower respiratory rates are used. The 2010 ACLS guidelines recommend 8 to 10 breaths per minute with an advanced airway in place. We believe 6 to 8 breaths are adequate. In addition, we know that hyperventilation is harmful, as it leads to increased intrathoracic pressure, which decreases venous return and compromises cardiac output. A blindly inserted supraglottic airway, e.g., laryngeal mask airway, combi tube, laryngeal tube, can be placed without interrupting chest compressions, provides adequate ventilation in most cases, and reduces the risk of aspiration compared to bag mask ventilation. Therefore, clinicians may prefer to ventilate with a supraglottic device while CPR is ongoing, rather than performing tracheal intubation. Sudden cardiac arrest. Ventricular fibrillation and pulseless ventricular tachycardia. Ventricular fibrillation, VF, and pulseless ventricular tachycardia, VT, are non-perfusing rhythms emanating from the ventricles, for which early rhythm identification, defibrillation, and cardiopulmonary resuscitation, CPR, are the mainstays of treatment. Begin performing excellent chest compressions as soon as sudden cardiac arrest, SCA, is recognized and continue while the defibrillator is being attached. If a defibrillator is not immediately available, continue CPR until one is obtained. As soon as a defibrillator is available, attach it to the patient, charge it, then assess the rhythm, and treat appropriately, e.g., defibrillate VF or pulseless VT, continue CPR if asystole or P. Resume CPR immediately after any shock is given. Biphasic defibrillators are recommended because of their increased efficacy at lower energy levels, 22 to 24. The 2010 ACLS guidelines recommend that when employing a biphasic defibrillator, clinicians use the initial dose of energy recommended by the manufacturer, 120 to 200 J. If this dose is not known, the maximal dose may be used. We suggest a first defibrillation using 200 J with a biphasic defibrillator or 360 J with a monophasic defibrillator for VF or pulseless VT. It should be noted that many automated external defibrillators, AEDs, do not allow for adjustment of the shock output. If VF or pulseless VT persists after at least one attempt at defibrillation and 2 minutes of CPR, give epinephrine, 1 mg for every 3 to 5 minutes, while CPR is performed continuously. Vasopressin, 40 units may replace the first or second dose of epinephrine. Evidence suggests that antiarrhythmic drugs provide little survival benefit in refractory VF or pulseless VT. We suggest that antiarrhythmic drugs be considered after a second unsuccessful defibrillation attempt in anticipation of a third shock. Amiodarone, 300 mg with a repeat dose of 150 mg is indicated, may be administered in VF or pulseless VT unresponsive to defibrillation, CPR, and epinephrine. Lidocaine, 1 to 1.5 mg/kg then 0.5 to 0.75 mg/kg every 5 to 10 minutes, may be used if amiodarone is unavailable. Magnesium sulfate, 2 grams followed by a maintenance infusion, may be used to treat polymorphic ventricular tachycardia consistent with torsade de pointes. Asystole and pulseless electrical activity. Asystole is defined as a complete absence of demonstrable electrical and mechanical cardiac activity. Pulseless electrical activity, PEA, is defined as any one of a heterogeneous group of organized electrocardiographic rhythms without sufficient mechanical contraction of the heart to produce a palpable pulse or measurable blood pressure. By definition, asystole and PE are non-perfusing rhythms requiring the initiation of excellent CPR immediately when either is present. In the 2010 ACLS guidelines, asystole and PE are addressed together because successful management for both depends on excellent CPR, vasopressors, and rapid reversal of underlying causes, such as hypoxia, hyperkalemia, poisoning, and hemorrhage. 18. Asystole may be the result of a primary or secondary cardiac conduction abnormality, possibly from end-stage tissue hypoxia and metabolic acidosis, or, rarely, the result of excessive vagal stimulation. It is crucial to identify and treat potential secondary causes of asystole or P as rapidly as possible. Some causes, e.g., tension pneumothorax, cardiac tamponade, result in ineffective CPR. Neither asystole nor P responds to defibrillation. Neither asystole nor P responds to defibrillation. Atropine is no longer recommended for the treatment of asystole or P. Cardiac pacing is ineffective for cardiac arrest and not recommended in the 2010 ACLS guidelines. In summary, treatment for asystole and P consists of early identification and treatment of reversible causes and excellent CPR with vasopressor administration until either ROSC or a shockable rhythm occurs. Monitoring. The 2010 ACLS guidelines encourage the use of clinical and physiologic monitoring to optimize the performance of CPR and to detect the return of spontaneous circulation, ROSC. 5. Assessment and immediate feedback about important clinical parameters, such as the rate and depth of chest compressions, adequacy of chest recoil between compressions, and rate and force of ventilations, can improve CPR. Entitled Carbon Dioxide, ECO2. Measurements from continuous waveform capnography accurately reflect cardiac output and cerebral perfusion pressure, and therefore the quality of CPR. Sudden, sustained increases in ECO2 during CPR indicate a ROSC, while decreasing ECO2 during CPR may indicate inadequate compressions. Measurements of arterial relaxation provide a reasonable approximation of coronary perfusion pressure. During CPR, a reasonable goal is to maintain the arterial relaxation, or diastole, pressure above 20 mm of mercury. Central venous oxygen saturation, SCVO2, provides information about oxygen delivery and cardiac output. During CPR, a reasonable goal is to maintain SCVO2 above 30%. Bradycardia. Bradycardia is defined conservatively as a heart rate below 60 beats per minute, but symptomatic bradycardia generally entails rates below 50 beats per minute. The 2010 ACLS guidelines recommend that clinicians not intervene unless the patient exhibits evidence of inadequate tissue perfusion thought to result from the slow heart rate. 18. Signs and symptoms of inadequate perfusion include hypotension, altered mental status, signs of shock, ongoing ischemic chest pain, and evidence of acute pulmonary edema. Hypoxemia is a common cause of bradycardia. Look for signs of labored breathing, e.g., increased respiratory rate, retractions, paradoxical abdominal breathing, and low oxygen saturation. Mild symptoms may not warrant treatment. If any significant symptoms are present in the setting of bradycardia, administer atropine, if easily done, and immediately prepare to treat the patient with transcutaneous pacing or an infusion of a chronotropic agent, dopamine or epinephrine. Do not delay treatment with transcutaneous pacing or a chronotropic agent in order to give atropine. The initial dose of atropine is 0.5 mg for. The initial dose of atropine is 0.5 mg for. This dose may be repeated every 3 to 5 minutes to a total dose of 3 mg. Do not give atropine if there is evidence of a high degree, second degree, Mobitz, type 2 or third degree, atrioventricular, avenue, block, 29. Infusions of dopamine are dosed at 2 to 10 micrograms/kg per minute, while epinephrine is given at 2 to 10 micrograms per minute. Each is titrated to the patient's response. If neither transcutaneous pacing nor infusion of a chronotropic agent resolves the patient's symptoms, prepare for transvenous pacing and obtain expert consultation if available. Patients requiring transcutaneous or transvenous pacing also require cardiology consultation and admission for evaluation for permanent pacemaker placement. Common toxicologic causes of symptomatic bradycardia include supratherapeutic levels of beta blockers, calcium channel blockers, and digoxin. Approach. Tachycardia is defined as a heart rate above 100 beats per minute, but symptomatic tachycardia generally involves rates over 150 beats per minute, unless underlying ventricular dysfunction exists. 18. The fundamental approach is as follows. First, determine if the patient is unstable, e.g., manifests ongoing ischemic chest pain, acute mental status changes, hypotension, signs of shock, or evidence of acute pulmonary edema. Hypoxemia is a common cause of tachycardia. Look for signs of labored breathing, e.g., increased respiratory rate, retractions, paradoxical abdominal breathing, and low oxygen saturation. If instability is present and appears related to the tachycardia, treat immediately with synchronized cardioversion, unless the rhythm is sinus tachycardia. 30. Some cases of supraventricular tachycardia may respond to immediate treatment with a bolus of adenosine, 6 to 12 mg, without the need of cardioversion. Whenever possible, assess whether the patient can perceive the pain associated with cardioversion, and if so, provide appropriate sedation and analgesia. Tachycardia. In the stable patient, use the electrocardiogram, ECG, to determine the nature of the arrhythmia. In the urgent settings in which ACLS algorithms are most often employed, specific rhythm identification may not be possible. Nevertheless, by performing an orderly review of the ECG, one can determine appropriate management. 3 questions provide the basis for assessing the electrocardiogram in this setting. Is the patient in a sinus rhythm? Is the QRS complex wide or narrow? Is the rhythm regular or irregular? Regular, narrow, complex. Sinus tachycardia and supraventricular tachycardia are the major causes of irregular narrow complex arrhythmia. 18. Sinus tachycardia is a common response to fever, anemia, shock, sepsis, pain, heart failure, or any other physiologic stress. No medication is needed to treat sinus tachycardia. Care is focused on treating the underlying cause. Supraventricular tachycardia, SVT, is a regular tachycardia most often caused by a reentrant mechanism within the conduction system. The QRS interval is usually narrow, but can be longer than 120 ms if a bundle branch block, SVT with aberrancy or fixed bundle branch block, is present. Vagal maneuvers, which may block conduction through the avenue node and result in interruption of the reentrant circuit, may be employed on appropriate patients while other therapies are prepared. Vagal maneuvers alone, e.g., Valsalva, carotid sinus massage, convert up to 25% of SVTs to sinus rhythm. 31,32. Because of its extremely short half-life, adenosine, 6 to 12 mg, is injected as rapidly as possible into a large proximal vein, followed immediately by a 20 ml saline flush and elevation of the extremity to ensure the drug enters the central circulation before it is metabolized. If the first dose of adenosine does not convert the rhythm, a second and third dose of 12 mg may be given. Larger doses, e.g., 18 mg, may be needed in patients taking theophylline or theobromine, or who consume large amounts of caffeine. Smaller doses, e.g., 3 mg, should be given to patients taking dipyridamole or carbamazepine, those with transplanted hearts, or when injecting via a central vein. Irregular narrow complex. Irregular narrow complex tachycardias may be caused by atrial fibrillation, atrial flutter with variable atrioventricular avenue, nodal conduction, multifocal atrial tachycardia, MAT, or sinus tachycardia with frequent premature atrial beats. 4. Of these, atrial fibrillation is most common. 18. The initial goal of treatment in stable patients is to control the heart rate using either a non-dihydropyridine calcium channel blocker, diltiazem 15 to 20 mg for over 2 minutes, repeat at 20 to 25 mg for after 15 minutes, or verapamil 2.5 to 5 mg for over 2 minutes followed by 5 to 10 mg for every 15 to 30 minutes, or a beta blocker, e.g., metoprolol 5 mg for 3 doses every 2 to 5 minutes, then up to 200 mg po every 12 hours. Calcium channel blockers and beta blockers may cause or worsen hypotension. Patients should be closely monitored while the drug is given, and patients at greater risk of developing severe hypotension, e.g., elders, often require loading doses that are below the usual range. Combination therapy with a beta blocker and calcium channel blocker increases the risk of severe heart block. Diltiazem is suggested in most instances for the management of acute atrial fibrillation with rapid ventricular response. Beta blockers may also be used and may be preferred in the setting of an acute coronary syndrome. Beta blockers are more effective for chronic rate control. For atrial fibrillation associated with hypotension, amiodarone may be used, 150 mg for over 10 minutes, followed by 1 mg per minute drip for 6 hours, and then half a milligram per minute, but the possibility of conversion to sinus rhythm must be considered. 35. For atrial fibrillation associated with acute heart failure, amiodarone or digoxin may be used for rate control. Treatment of MAD includes correction of possible precipitants, such as hypokalemia and hypomagnesemia. The 2010 ACLS guidelines recommend consultation with a cardiologist for these arrhythmias. Cardioversion of stable patients with irregular narrow complex tachycardias should not be undertaken without considering the risk of embolic stroke. If the duration of atrial fibrillation is known to be less than 48 hours, the risk of embolic stroke is low, and the clinician may consider electrical or chemical cardioversion. 36. Regular wide complex. A regular, wide complex tachycardia is generally ventricular in etiology. Aberrantly conducted supraventricular tachycardias may also be seen. Because differentiation between ventricular tachycardia, VT, and SVT with aberrancy can be difficult, assume VT is present. Treat clinically stable undifferentiated wide complex tachycardia with antiarrhythmics or elective synchronized cardioversion. 18. In cases of regular, wide complex tachycardia with a monomorphic QRS complex, adenosine may be used for diagnosis and treatment. Do not give adenosine to patients who are unstable or manifest wide complex tachycardia with an irregular rhythm or a polymorphic QRS complex. Adenosine is unlikely to affect ventricular tachycardia but is likely to slow or convert SVT with aberrancy. Dosing is identical to that used for SVT. Other antiarrhythmics that may be used to treat stable patients with regular, wide complex tachycardia include procainamide, 20 mg per minute for, amiodarone, 150 mg for given over 10 minutes, repeated as needed to a total of 2.2 grams for over the first 24 hours, and sotalol, 100 mg for over 5 minutes. A procainamide infusion continues until the arrhythmia is suppressed, the patient becomes hypotensive, the QRS widens 50% beyond baseline, or a maximum dose of 17 mg/kg is administered. Procainamide and sotalol should be avoided in patients with a prolonged QT interval. If the wide complex tachycardia persists, in spite of pharmacologic therapy, elective cardioversion may be needed. The 2010 ACLS guidelines recommend expert consultation for all patients with wide complex tachycardia. SVT with aberrancy, if definitively identified, e.g., old ECG demonstrates bundle branch block, may be treated in the same manner as narrow complex SVT, with vagal maneuvers, adenosine, or rate control. Irregular wide complex. A wide complex, irregular tachycardia may be atrial fibrillation with pre-excitation, e.g., Wolff-Parkinson-White syndrome, atrial fibrillation with aberrancy, bundle branch block, or polymorphic ventricular tachycardia, VT/Torsades step points, algorithm 4, 18. Use of atrioventricular, avenue, nodal blockers in wide complex, irregular tachycardia of unclear etiology may precipitate ventricular fibrillation, VF, and patient death, and is contraindicated. Such medications include beta blockers, calcium channel blockers, digoxin, and adenosine. To avoid inappropriate and possibly dangerous treatment, the 2010 ACLS guidelines suggest assuming that any wide complex, irregular tachycardia is caused by pre-excited atrial fibrillation. Patients with a wide complex, irregular tachycardia caused by pre-excited atrial fibrillation usually manifest extremely fast heart rates, generally over 200 beats per minute, and require immediate electric cardioversion. In cases where electric cardioversion is ineffective or unfeasible, or atrial fibrillation recurs, antiarrhythmic therapy with procainamide, amiodarone, or sotalol may be given. The 2010 ACLS guidelines recommend expert consultation for all patients with wide complex tachycardia. Dosing for antiarrhythmic medications is described above. See regular wide complex above. Treat polymorphic VT with emergent defibrillation. Treat polymorphic VT with emergent defibrillation. Interventions to prevent recurrent polymorphic VT include correcting underlying electrolyte abnormalities, e.g., hypokalemia, hypomagnesemia, and, if a prolonged QT interval is observed or thought to exist, stopping all medications that increase the QT interval. Magnesium sulfate, 2 grams 4, followed by a maintenance infusion, can be given to prevent polymorphic VT associated with familial or acquired prolonged QT syndrome. 37. A clinically stable patient with atrial fibrillation and a wide QRS interval known to stem from a pre-existing bundle branch block, old ECG demonstrates pre-existing block, may be treated in the same manner as a narrow complex atrial fibrillation. Post-resuscitation care. The 2010 ACLS guidelines recommend a combination of goal-oriented interventions provided by an experienced multidisciplinary team for all cardiac arrest patients with return of spontaneous circulation. 18. Important objectives for such care include optimizing cardiopulmonary function and perfusion of vital organs, managing acute coronary syndromes, implementing strategies to prevent and manage organ system dysfunction and injury. Management of the post-cardiac arrest patient is reviewed separately. Termination of resuscitative efforts. Determining when to stop resuscitation efforts in cardiac arrest patients is difficult, and little data exists to guide decision-making. Factors associated with poor and good outcomes are discussed in detail separately. Physician survey data and clinical practice guidelines suggest that factors influencing the decision to stop resuscitative efforts include 38 to 42. Duration of resuscitative effort greater than 30 minutes without a sustained perfusing rhythm. Initial electrocardiographic rhythm of asystole. Prolonged interval between estimated time of arrest and initiation of resuscitation. Patient age and severity of comorbid disease. Absent brainstem reflexes.